Welcome back, guys. So, today we'll be resuming Epidemiology of Communicable Diseases with leprosy. So, we need to know the cardinal features of leprosy and the small problem statement, in which you have the Global Leprosy Strategy 2021 to 30 plus strategic pillars. And then, of course, as usual, epidemiological determinants. Agent factors involve agent, source of infection, portal of exit, infectivity, and attack rates. Host factors involve age, sex, migration, prevalence pool, inactivation of disease, immunity, and genetic factors. There's higher incidence in males compared to females. And of course, environmental factors like socioeconomic status, hygiene, overcrowding, etc. The modes of transmission are droplet infection, contact transmission, and other routes. Then the incubation period is 3 to 5 years, or it can be even more than that. And we should also know the pathogenesis of leprosy. And based on there are a few classifications we need to know. So there's an Indian classification divides it into 5 stages. That's indeterminate, tuberculoid, borderline, lepromatous, and pure neuritic leprosy. According to the Madrid classification, we have indeterminate, tuberculoid or flat or raised, borderline, and lepromatous leprosy. According to the Ridley and Joplin classification, we have tuberculoid, borderline, borderline, borderline lepromatous, and lepromatous leprosy. Each of them are abbreviated as follows: TT, BT, BB, BL, and LL. Now, coming to the clinical classification for the control programs, according we can classify it into either paucibacillary or multibacillary leprosy based on these three criteria: skin lesions, peripheral nerve involvement, and slit skin smear. Under paucibacillary leprosy, there are 1 to 5 skin lesions, less than 1 peripheral nerve involved, and slit skin smears negative everywhere. But in multibacillary, you have more than 6 skin lesions, more than 1 peripheral nerve involved, and slit skin smear can be positive anywhere. There's an important diagram that shows the pathogenesis of leprosy. It's a must know. Then coming to the diagnostic criteria. Firstly, by clinical examination, we need to know the case history, then do a physical examination to test the sensation, and nerve examination. Another important diagram showing which nerves are to be examined. Then coming to bacteriological examination, we have skin smears, nasal smears or blows, and nasal scrapings. Then we have bacterial index, that's or Ridley's logarithmic scale. Then the morphological index, in which you need to have uniform staining, parallel sides, rounded ends, and length must be 5 times the width to count a bacillus. These are the necessary criteria to count a bacillus. Plus solid fragmented granular percentage. And then we also have foot pad culture, histamine test, biopsy, immunological tests like one to detect cell mediated immunity. We have the Leppermin test and LTT and LMIT. Leppermin test involves an early reaction and a late reaction. The early reaction is also called Fernandez reaction. The late reaction is also called as Mitsuda reaction. We also have tests for humoral response, in which you have FLA ABS, monoclonal antibodies, and others. FLA ABS stands for fluorescent leprosy antibody absorption test. Coming to leprosy control, we have medical measures which include estimation of the problem, early case detection, and multi-drug therapy. And which you should know the objectives of multi-drug therapy and various definitions, the definitions of a case, definition of paucibacillary case, multibacillary case, and adequate treatment, regular treatment, a newly diagnosed case, defaulter case, and a relapsed case. Then you should also know the various drugs we use, like rifampicin, dapsone, and clofazimine, which are very important because they are used in the NLEP regimen in India. Then quinolones, minocyclines, and clarithromycin can also be used. but the first three are the top three. We also have separate regimens for multibacillary and postbacillary, and in each we have separate regimens for adults and for children between 10 to 14 years of age, along with the duration of treatment. And we also have to know about the lepra reaction, how to differentiate type 1 reaction versus type 2 reaction, and how to manage each of them. And then a short note on steroids, which should be used in caution in pregnancy, children, diabetes, people with ulcers, people with osteomyelitis, eye involvement, and TB. So all of that was just under multi-drug therapy. Now continuing with the medical measures again, we have surveillance, which involves possibacillary and multibacillary surveillance, immunoprophylaxis and chemoprophylaxis. It's also important to know the difference between a reversal reaction and a relapse. There's a small table given for that same. And then we also learn about the disability, high risk categories, and stages of nerve involvement, which are stage 1, 2, and 3, along with the types of disability, which can be primary or secondary. We also have to differentiate disability and deformity. So there's a WHO grading of various deformities based on how much it occurs in the face, hands, feet, and other places like gynecomastia and palate perforation. Then we also have rehabilitation and health education. Next, we have social support, and then we have program management and evaluation, which involves epidemiological indicators like incidence and prevalence, and other indicators for surveillance and program performance, like essential indicators and additional indicators, which are included with the routine program targets of the National Leprosy Elimination Program, quality of service indicators, new performance indicators, and impact indicators. Then there's a small note on other anti-leprosy activities that the government carries out. With that, we finish leprosy. Now we start with sexually transmitted diseases or infections, STDs or SDIs. So we should know the classification. It can be based on their pathogens. They may be classified as bacterial, viral, protozoal, fungal, or by ectoparasites. Fungal, the most common is Candida albicans. Protozoal, the top three are Entamoeba histolytica, Giardia lamblia, and Trichomonas vaginalis. Ectoparasites, the most common ones are Cyrus pubis and Sarcoptes scabii. So, in the problem statement, we should read about the true incidence of STDs and the consequences of STIs, because not everyone comes to the hospital when they have an STD due to the social stigma surrounding it and other factors as well. So in India, the most common STDs are syphilis, gonorrhea, chancroid, LGV, and lymphogranuloma venereum, and donovanosis or granuloma inguinale, and of course HIV as well. Under epidemiological determinants, we need to know the agent factors and the host factors, including age, sex, marital, and socioeconomic status. We also have demographic factors and other social factors like prostitution, broken homes, sexual disharmony, easy money, which goes hand in hand with prostitution, emotional immaturity, urbanization and industrialization, social disruption, international travel, changing behavioral patterns, social stigma, and alcoholism. So after this, there are clinical features listed for few of the most common diseases like gonococcal infection, syphilis, chlamydial infection, trichomoniasis, chancroid, lymphogranuloma venereum, donovanosis, genital herpes, and human papilloma virus. Followed by a syndromic approach, in which you have the common sequelae and syndromes. There's a table that would help you in reading the same. And then you have various algorithms for the syndromic management of urethral discharge, syndromic management of vaginal discharge, urethral discharges in males, management of lower abdominal pain in females, management of genital ulcers, management of scrotal swelling, and management of inguinal buboes. So there are 6 algorithms. They look bulky, but you can just take the management part of it, which is pretty easy. We also, again, anyway, we have it given in the text as well separately as the management of STDs, which involves service delivery measures, including continuum of STDs, which to be disrupted, intervention packages, prevention for STDs, vaccines for STDs, vertical transmission of STIs, STI awareness and treatment seeking behavior to be encouraged, case management for symptomatic STIs, sexual partner services for STIs, screening priority populations for STIs, and treatment for complications and sequelae that can arise, along with drug resistance and new diagnostic and treatment strategies, and linking STI services with other health services so that it's more approachable. Along with a small note on global health sector strategy on HIV, hepatitis, and STDs 2022 to 2030, and the National STD Control Program. This is not usually asked, so you can skip it if you want. Now, coming to endemic treponematosis. So, we have something called PINTA, which is caused by Treponema caretium, which is seen in Latin America. And the late stage of this disease gives resistance to Treponema pallidum. The next disease is endemic syphilis. It's also called Behel in Syria. It's common in the Middle East, Africa, and Australia. PINTA and endemic syphilis are transmitted by a non-venereal contact transmission. Next, we have yaws, which is another chronic non-venereal disease. You know its geographic distribution, its epidemiological determinants, in which have, of course, agent factors like agent, reservoir, and communicability. Host factors include age, sex, and immunity. Yaws provides partial immunity against venereal syphilis. And environmental factors like climate and social factors. The modes of transmission are direct contact, fomite, and vectors, and an incubation period of 9 to 19 days is present. Come to the clinical features, we should know the features of early yaws and late yaws. Late yaws is what develops 5 years after the onset of early yaws. We should know 3 terms here, which I forgot to mention: gangosa, goundu, and crab yaws. Coming to yaws control measures, we have survey and treatment, of course, with either single dose oral azithromycin or IV injection of benzathine penicillin G, and simultaneous treatment of all clinical cases and contacts. There are 3 treatment policies given by WHO, which can be total, juvenile, or selective mass treatment. There's also note on resurvey and treatment, surveillance, environment improvement, and renewed eradication effects, including total community treatment and total targeted treatment, and of course, evaluation of the above measures. Now, moving to the next disease, a very important one: AIDS, or acquired immunodeficiency syndrome, caused by the human immunodeficiency virus, or HIV. So, another problem statement we need to know about: low level, concentrated, and generalized HIV epidemics. And we should know that it's the leading cause of death in women of reproductive age, that's non gestating women. You should also know about the 90-90-90 and 95-95-95 strategies. One that's going on right now is 95-95-95 strategy. And of course, the high risk groups in India, which consists of female sex workers, men having sex with men, injecting drug users, hijra or transgender population, migrants, truckers or truck drivers, prison inmates, and link workers scheme. We then move on to epidemiological determinants, in which we deal with the agent factors and host factors. We need to know the agent, reservoir, source, and under host factors, age, sex, and high risk group, and especially sexual practices. We also learn about the immunology and modes of transmission, which can be sexual, parenteral, or vertical. Incubation period can stretch from few months to 10 years to more than 10 years. So the clinical features, you need to know about the initial infection with virus and development of antibodies, the asymptomatic carrier state, AIDS related complex, and AIDS, which is a complex of opportunistic infections such as TB, persistent generalized lymphadenopathy, Kaposi sarcoma, oropharyngeal candidiasis, cytomegalovirus retinitis, pneumocystis carinii pneumonia, toxoplasma encephalitis, hairy leukoplakia, streptococcal meningitis, herpes zoster or shingles, severe prurigo or pruritic dermatitis, severe or recurrent skin infections. Now coming to the diagnosis of HIV, we should know that clinically, we should know the WHO case definitions for AIDS surveillance, which consist of major signs and minor signs. There should be more than 2 major signs and more than 1 minor sign. So the things to be noted are that when TB co-infection is present, persistent cough is not a minor sign, and the presence of Kaposi sarcoma or cryptococcal meningitis is enough to diagnose the case as AIDS positive for surveillance activities. And then there's another expanded WHO case definition as well. Now coming to the WHO clinical staging system, we divide it into stages 1, 2, 3, and 4 for adults, and in kids we have another set of criteria to divide it into stages 1, 2, and 3. There are two tables. The one with for adults, stages 1 to 4, is very important. It's a must read. It will help you in medicine as well. Coming to the laboratory diagnosis, we have screening tests, and we have two tests that are usually performed. The second one is confirmatory. The first is usually ELISA, and second confirmatory test is usually a Western blot, and also virus isolation. There's another table for various tests used to diagnose, which would be very helpful. Coming to control measures, we have prevention, which involves education, and combination HIV prevention, which involves male and female condoms plus compatible lubricants, needle and syringe programs, opioid substitution therapy, and voluntary medical male circumcision. After that, we also have prevention of bloodborne transmission. Then we have antiretroviral therapy. It's therapy, not transmission, guys. Please forgive me for the same. Classification of drugs is very important. And HIV care and management recommendations according to NACO 2021 is also important. Antiretroviral therapy in adults and adolescents. So you should know the clinical, virological, immunological, therapeutic, and preventive goals of ART. Then the various ART regimens, and also rapid initiation of newly diagnosed PLHIV, people living with HIV, at ART centers. There's an algorithm for that. Then monitoring of patients on ART, general guidance, pediatric first-line ART regimens, and occupational HIV post-exposure prophylaxis for percutaneous injury. The most common example is needle stick injuries, and contact with mucous membranes or non-intact skin. So one thing you should know in these scenarios, that fluids are not infectious unless they are visibly bloody. So these are the following fluids that you can be a bit chill about, like feces, nasal secretions, saliva, sputum, sweat, tears, urine, and vomitus, plus few treatment recommendations and preferred regimens to handle those situations. Then we also see the use of cotrimoxazole prophylaxis for HIV related infections, HIV and TB co-infections, monitoring efficacy of ART, then specific prophylactic measures for PCP, pneumocystic pneumonia, Mycobacterium avium complex, MAC, cytomegalovirus retinitis, candidiasis, and herpes zoster virus. Then primary healthcare measures to tackle the spread of HIV, and of course NACP, the National AIDS Control Program. So then we move on to emerging and re-emerging infectious diseases. So emerging diseases are COVID-19, human monkeypox, tomato fever or flu, AIDS, Ebola, and E. coli, influenza, and the role of drug resistance in causing the re-emergence of in many infections like TB and malaria, which faces a problem of double resistance because it's vector borne. The pathogen can become resistant, and the vector itself can become resistant to particular vector control measures. Then we also have enterococci, streptococci, Neisseria gonorrhoeae, and Shigella dysentery that are re-emerging. So we also know how to respond to epidemics of the same. Coming to our last category of diseases, that's hospital acquired infections, with the definition of nosocomial infections plus the types of nosocomial infections for which there's a table. Then the sources of hospital acquired infections can be patients, staff, or the environment. Patients can be a source of viral, skin, respiratory, or urinary infections. The routes of spread are many. It can be direct contact, or droplet, or airborne, or hospital dust, and other various hospital procedures. There are preventive measures that can be taken to easily prevent it, like isolation of infected cases, hospital staff, education, training, hand washing, dust control, disinfection, control of droplet infection, appropriate nursing techniques, and administrative measures. There are other standard routine precautions that have to be taken, like protective clothing consisting of gowns, gloves, and a mask, and other general precautions, which are shown in a table showing what measures can be effective and ineffective for 4 infections. Lastly, we have a very small note on reviewing employee health, providing appropriate immunization, specific post exposure prophylaxis, providing appropriate immunization for hospital employees, specific, or not hospital, healthcare employees, specific post exposure policies for these diseases, that's HIV, hepatitis A or B or C or E, Neisseria meningitidis, TB, varicella zoster, diphtheria, pertussis, and rabies. So, with that, we complete this long chapter on epidemiology of communicable diseases. So, if you have stayed till this point in the video, thank you very much. I appreciate it a lot. So, if you have any suggestions and honest feedback, you can comment down below. If you found it helpful, please like, share, and subscribe. I hope I could help you study for community medicine, and I hope this helps in other subjects as well. So, thanks for watching once again. See you soon.